Imagine a country with, well, over 1 billion people, stretching from these huge mountains to vast plains, cities, tiny rural villages. How does a nation like that, so incredibly diverse, manage to stitch together a healthcare safety net? Making sure even basic medical care reaches, well, everyone.
It's a huge question.
It's not just a challenge, it feels like a monumental feat of planning, of human dedication.
Absolutely.
So today we're pulling back the curtain on that blueprint. We're taking a deep dive into India's primary healthcare system.
That's right. And our mission today, really, is to unpack the layers of this system.
Yeah.
Quite intricate.
Layers sounds right.
Yeah. We'll explore its foundations, the principles behind it. Then there's this ingenious three-tier infrastructure. It branches out from cities right down to the smallest hamlets.
Okay.
We'll talk about the dedicated health workforce, the living backbone, really, and also the crucial role NGOs, non-governmental organizations, play. They support and innovate.
Right. So support and innovation.
Exactly. We've looked at a whole range of sources that outline the system, its delivery. The idea is to give you a clear, structured, and hopefully a kind of surprising look at how it all fits together.
Okay, sounds like a great mission. Let's peel back that first layer then. Before we get into the how, let's start with the what. What exactly is primary healthcare, PHC, specifically in the Indian context?
Okay, so at its core, PHC is about essential healthcare, but it has to be practical and scientifically sound.
Practical and sound, right.
What's really, I think, revolutionary here is the design. It aims to be universally accessible, culturally acceptable.
That acceptance piece is huge.
It is, and deeply rooted in full community participation. And affordability, of course. It's not just a clinic down the road. It's the very first point of contact people have with the national health system. It tackles the most common health problems, but crucially, it also tries to foster this spirit of self-reliance within communities.
So it's not just about providing a building, but making healthcare relevant, reachable, and kind of owned by the people it serves.
Exactly. Owned by the people. That's a great way to put it.
So what are the key principles then? The things that really guide this huge approach?
Right. Well, the PHC approach is built on several really vital principles that shape how it's delivered. First up is equitable distribution.
Okay, equitable.
And this isn't just, numbers. It's about distributing health resources according to need, actual
Need, not just population density or something.
Precisely. So often that means a deliberate shift, focusing away from, say, concentrated urban centers towards the vast, often underserved rural areas, trying to make services genuinely accessible to everyone.
And how do they do that? I mean, practically.
Well, our sources mention things like dedicated mobile medical units that actually travel through remote tribal areas, bringing healthcare directly to people, or specific ways they allocate resources, prioritizing districts based on health indicators, not just how many people live there.
Wow, that's adaptive.
It has to be. Constant adaptation.
Yeah, it really highlights the scale of the challenge, doesn't it? Overcoming geography, infrastructure hurdles.
Absolutely. Then there's community participation and involvement. This one's paramount.
Community participation.
Yeah. No health service can really work without active understanding, active involvement from the community itself.
Right.
Think of it like individuals, families, whole communities taking real responsibility for their own health and actively participating, planning, implementing, even evaluating the services.
And are there examples of that? Like, who makes that happen?
Oh, definitely. Our sources point to figures like village health guides, trained diests, traditional birth attendants, and especially the accredited social health activists.
Yeah.
We call them ASHs. They're key in making this participation real.
ASHs. We'll come back to them, I bet.
We will. Then what about technology?
Right, the tech side. I imagine it needs to be effective, but also super practical and fit the local scene.
Exactly. That's appropriate technology.
Yeah.
It means health methods, tools that are scientifically sound, yes, but also socially acceptable and, crucially, affordable.
Affordable is key.
Always. We're talking about things like life-saving oral rehydration solutions, ORS.
Oh, yeah, ORS.
Widespread immunization programs, vaccine vial monitors, these little stickers that show if a vaccine got too hot.
Ah, clever.
Simple, disposable delivery kits for childbirth. These are practical, often low-cost things that make a huge difference in basic care.
It makes so much sense. Health isn't just in a bubble, is it?
Not at all.
Which brings us to another principle our sources mention, intersectoral coordination. Working together across different areas.
Definitely. This principle basically says health outcomes aren't just the health department's job.
Right.
PHC needs real collaboration with agriculture, education, housing, public works, you name it.
Can you give an example?
Yeah, a fantastic one from the sources is the Midday Meal Scheme. It's run by the Education Department, providing school lunches.
Ah, the school meal program.
Right, but it contributes massively to child nutrition and health. It shows how linked everything is.
That's a great illustration.
And these principles, they work hand in hand with the 8 essential components from the Alma Ata Declaration. That covers everything from health education, promoting nutrition, safe water, sanitation, maternal and child care, family planning, immunization, controlling local diseases, treating common problems, and providing essential drugs. It's a whole vision for well-being.
Okay, so we have these powerful principles. Equitable distribution, community involvement, appropriate tech working together. Now, the big question, how do you actually do this? Across a nation of over 1 billion, this is where that 3-tier system you mentioned comes in, right?
Yes, exactly. It's this really meticulously structured system designed to branch out, reach almost every corner.
Okay, walk us through it. Tier 1.
So Tier 1, the village level. This is the most peripheral level, you could say the most crucial. It's where direct community engagement happens.
Right on the ground.
Yes, exactly. Through various frontline health workers. Their focus, health promotion, dealing with minor sicknesses, first aid.
Who are these workers?
Well, you have village health guides, VHDs, chosen per 1,000 people, usually local women, trained for basic stuff, giving out contraceptives, tracking births and deaths. They're like the face of primary care for rural folks.
The face of care, I like that.
Then there are trained dais. These are traditional midwives, but they get training to ensure safer deliveries, offer family planning advice, motivate couples. The goal is at least 1 per village.
Okay.
Then you have Anganwadi workers, AWWs. They work under a big program called ICDS, Integrated Child Development Services.
Ah, the Anganwadis. Heard of them.
Yeah, they provide supplementary food, immunization, health checkups, track children's growth, even run non-formal preschools. And they guide the ASHAs too.
Guiding the ASHAs. And then, yes, the accredited social health activists, ASHAs. Female health activists, a vital bridge. We'll definitely dig into their role more later. Okay, so if these village workers are the first point of contact, the sub-centers sound like the next step up. How do they build on that?
Exactly. That takes us to Tier 2, health subcenters, HSCC SSCs. A subcenter usually serves about 5,000 people in the plains, maybe 3,000 in hilly or tribal areas.
Right.
They are the peripheral outposts, the first point of sustained contact between the formal healthcare system and the community.
Sustained contact. Okay,
Yeah.
What do they do?
Their functions are pretty comprehensive. Maternal and child health, MCH care. That means antenatal checkups, helping with normal deliveries, postnatal care, routine immunizations, spotting high-risk pregnancies.
So a lot of mother and baby care.
A huge amount. Plus family planning, giving out contraceptives, inserting or removing IUDs, counseling, also treating minor things like diarrhea, respiratory infections, disease surveillance, adolescent health care, checking water quality.
It sounds like a lot for one center.
It is. And what's often missed is the sheer ingenuity needed. The sources talk about the A&M's auxiliary nurse midwives, often working alone in huge areas. They become community leaders, build trust, deliver care with very few resources. It's amazing resilience.
A&Ms, who staffs these centers typically?
Usually 2 multi-purpose health workers, 1 female, the A&M, and 1 male. Nowadays, these are often called health and wellness centers, sub-health centers, or HWC-SHCs.
HWC-SHCs. Got it. And then moving up again, we get the primary health centers, the PHCs. What makes them different?
Right, Tier 3. Primary health centers, PHCs. A PHC is a bigger deal. Serves more people, 30,000 in plains, 20,000 in hilly areas. Think of it as the main hub for a group of sub-centers.
Okay, a central hub.
And they offer a much wider range of services. Integrated preventive, promotive, and curative care.
Curative too, so treatment.
Yes. They handle outpatient services, 24-hour emergency care, first aid, even minor surgeries like sterilizations or MTPs, medical termination of pregnancy, often using manual vacuum aspiration, MVA.
Okay, so more procedures.
Definitely. They also expand on MCH care, normal deliveries, newborn care, promoting breastfeeding, running immunization and nutrition programs, comprehensive family planning, including organizing special camps. They're key for controlling local diseases, doing health education.
But connecting upwards.
Crucially, yes.
Yeah.
They provide referral services to higher levels if needed, and they're responsible for training the lower-level workers, like the ASHAs and DAIS. Plus, they have basic laboratory services for common tests.
Training is important.
Very. These are also now often called HWC PHCs, Health and Wellness Center PHCs.
Okay, so a PHC sounds pretty comprehensive. How is it different from, say, a hospital? Where's the line?
That's a good question. A PHC provides that mix preventive, promotive, curative, but for a defined population in a specific area. It focuses on essential, community-level care.
Right, defined population.
A hospital, on the other hand, is mainly about curative services, often more specialized. It deals with more complex conditions and usually doesn't have a fixed catchment area like a PHC. It's a higher-level referral point for more advanced care, maybe inpatient stays.
Got it. So PHC is community-focused essential care. Hospitals are for more complex, specialized treatment.
Broadly, yes.
So what happens then if a health issue gets too complex for even a PHC? Needs more specialization, what's the next step up?
That's where community health centers, CHCs, step in.
CHEs. Okay.
A CHC serves an even larger population, maybe 100,000 in plains, 80,000 in hilly areas. They're essentially upgraded PHCs, often at the block level with significantly more resources. They act as the first referral level, often called an FRU, first referral unit.
FRU, first referral unit. What makes them first referral?
They handle more complex stuff, mostly curative. They're equipped for urgent emergency care, medical, surgical. They have 24-hour delivery services, including C-sections and emergency obstetric care, EMOC.
C-sections too. That's critical for maternal mortality.
Absolutely pivotal. They also have comprehensive newborn care, sometimes special newborn care units, SNCUs, advanced family planning like laparoscopic sterilizations, safe abortion services beyond just MVA,
Wow, okay.
more advanced procedures.
Yes, and importantly, they usually house a blood bank, essential laboratory and x-ray facilities. And this is key, they have specialist doctors.
Specialists. Okay, that's a big difference.
Huge. Specialists in medicine, gynecology, obstetrics, surgery, anesthesia, pediatrics.
Ah, so it's the specialists plus X-ray blood bank. That's what really sets a CHC apart from a PHC.
Precisely. PHCs handle the common stuff, keep the community healthy. CHCs are equipped for the more complex cases, the emergencies, and act as that vital referral bridge, stabilizing patients before maybe sending them on to a district hospital if even more advanced care is needed.
Right. It's a clear escalation pathway.
Exactly.
It's so clear that none of this whole structure, would work without the people, the actual humans doing the work. Let's shift focus now to that incredible health workforce. They really bring this blueprint to life. Indeed. They are the absolute backbone. Let's start with the health worker female, often called an A&M, auxiliary nurse midwife, or sometimes MPHWF, multipurpose health worker female.
The A&M we mentioned at the subcenter?
That's her, a crucial frontline worker at that subcenter level. And her responsibilities, they're just vast.
Like what?
Supervising other workers, running weekly maternal and child health clinics, providing care before and after birth, promoting breastfeeding, making sure immunizations happen, spotting high-risk pregnancies, running family welfare clinics, providing IUD services, identifying and referring diseases, educating on sanitation, giving primary care for minor sicknesses, and keeping meticulous records of everything.
Wow. That's a lot for one person.
It is. And in cities, you have female health workers, FHWs, doing similar vital roles.
Okay. And the ASAs, you flagged them earlier as community catalysts. They sound really unique. What makes their role stand out so much?
They absolutely are unique. And Asha, accredited social health activist, is a truly special figure. She's a female health activist, chosen from her community, accountable to her local panchayat, the village council.
Chosen from the community itself.
Yes, and that's key. She serves as this crucial link between the community, the Anganwadi worker, and the A&M. She's technically an honorary volunteer getting paid based on performance.
Performance-based pay. Interesting. What's revolutionary about them?
Well, it's not just the services, it's how she delivers them. She actively breaks down social, cultural barriers that the formal health system sometimes struggles with.
Ah, the trust factor.
Exactly. Our sources show how Ashes, being local, gain trust where outsiders might face resistance. This leads to much higher rates of things like women getting antenatal care or kids getting immunized in their villages. They're not just health workers. They're true community catalysts.
So what are her specific tasks?
She creates awareness about health issues, gets the community mobilized to use services, counsels women on everything, birth preparedness, contraception, nutrition. She helps people physically get to the Anganwadi, the subcenter, the PHC. She even escorts women and children during
It's an
emergencies.
escort, too. Wow.
Yeah. Plus, she's a primary care provider for minor ailments. And she's a depot holder. She keeps stocks of essential things like ORS, iron folic acid tablets, condoms. She even helps deliver DOTS therapy for tuberculosis.
DOTS for TB. She really covers a lot of ground.
She embodies community participation. She's the eyes and ears on the ground.
Incredible role. And then leading these teams at the PHC level, you have the doctors, the medical officers, you call them the captain. What's their scope?
Yes, the physician, usually the medical officer at the PHC, is really the leader of the health team there. Their role is incredibly multifaceted.
How so?
Well, first, care of the individual. Assessing health, diagnosing, managing common conditions, first aid, handling emergencies, referring people up the chain when needed, and delegating work to the team.
Okay, the clinical side.
Right. But then there's care of the community, leading the team to implement those 8 essential elements of PHC we talked about. Understanding the health needs of the whole community, coordinating the sub-centers under them, making sure national health programs actually happen on the ground.
So individual care and community management.
And they're also a teacher and educator,
Yeah.
using their position to educate individuals, families, communities, promoting self-care, getting people involved.
Using their standing in the community.
Exactly. And finally, managerial functions, planning programs, making sure the vaccine cold chain works, supervising field work. It's a demanding job, needs sharp medical skills and strong leadership. And often they work alongside practitioners of traditional Indian medicine too, the AYUSH practitioners.
Right. Ayurveda, yoga, Unani, Siddha, homeopathy. A holistic approach.
Reflecting that, yeah.
Okay, this is clearly a massive system, mainly driven by the government. But are there other significant players involved, people filling gaps, maybe trying new things?
Absolutely. Non-governmental organizations, NGOs, play an incredibly important, often pioneering role.
NGOs.
These are autonomous, usually privately funded groups. Yeah. Their goal is advancing public health through services, education, research, even pushing for better health laws. What's interesting is their agility. They can often adapt and try things faster than large government bodies.
Agility is key. So beyond just plugging resource gaps, what are their main functions? How do they contribute?
They do several critical things. One is supplementing government agencies, providing people, funds, services, strengthening government efforts, especially where resources are tight.
Okay, supplementing.
But maybe even more powerful is their ability to pioneer new approaches. NGOs are often in a unique spot to explore, to test innovative health ideas. They act like incubators.
Incubators for health ideas.
Exactly. And if something works, it can then be adopted and scaled up by the government. A classic example from our sources is the family planning program in India. Voluntary agencies really pioneered that. It shows the long-term impact NGOs can have.
Wow, they started family planning? That's huge.
It's foundational. They also play a vital role in education, complementing government efforts, informing the public, promoting healthy habits across all sorts of communities.
And it sounds like they can also be a bit of a watchdog or an advocate.
Indeed. They often set up demonstration projects, like the Rockefeller Foundation funded borehole latrines to fight hookworm decades ago. It showed a practical solution.
All proof of concept.
Exactly. They also excel at guiding and criticizing government agencies, constructively, of course, providing feedback, setting good examples, pushing for better quality, and critically, they can advance health legislation, mobilizing public support for laws that can really transform public health. The National Rural Health Mission, for instance, explicitly aimed to integrate NGOs more, promote collaboration, recognizing their value.
Okay, so a multifaceted role. Our sources highlighted one specific NGO, the Indian Red Cross Society. What can you tell us about their impact?
The Indian Red Cross, yes, established way back in 1920, a hugely prominent NGO. Their core mission is improving health, preventing disease, reducing suffering.
A classic humanitarian mission.
And they're legendary for their relief work, mobilizing resources, providing immediate aid during disasters, earthquakes, floods, epidemics, often the first ones there.
Disaster relief, okay.
They provide crucial medical supplies and assistance to hospitals, clinics, MCH centers, even schools and orphanages. delivering things like milk powder, medicines, vitamins where they're desperately needed. They also offer armed forces support, caring for sick and wounded soldiers. They even run a home in Bangalore for permanently disabled ex-servicemen.
Their reach sounds incredibly broad, touching so many different areas.
It is truly comprehensive. They're deeply involved in maternal and child welfare, running or supporting numerous MCH centers, offering technical advice, financial aid across the country. They also run family planning clinics in several states.
Family planning, too.
Yes. Plus, they establish essential blood banks. And through the St. John Ambulance Association, they tirelessly train people in first aid and home nursing, empowering communities with life-saving skills.
Training the public in first aid, that's vital.
Absolutely. And finally, the Junior Red Cross, getting young people involved in community work, first aid, anti-epidemic efforts, promoting international understanding. It's just a remarkably comprehensive approach to public health and aid. It really shows the power of an NGO weaving itself into the very fabric of a nation's health system.
What an incredible deep dive we've taken. We journeyed through those foundational principles of primary healthcare equity, community, coordination. We explored that intricate three-tier system in rural India, right from the village grassroots up to the community health centers.
Yeah, quite a journey.
We met the people, the dedicated workforce, from the ASHAs acting as catalysts to the physicians leading the teams, and we uncovered the invaluable, often groundbreaking role of NGOs like the Indian Red Cross.
You can really see how this vast, complex system gets built, can't you?
Yeah.
With the community right at its heart, reaching individuals through this network of committed people and essential infrastructure.
Yeah.
It's really a testament to the idea that health is a shared responsibility. It needs this multifaceted approach to tackle the unique challenges of such a diverse population. And, understanding India's system isn't just about India. It offers some incredible, maybe surprising lessons for how other large, diverse nations can think about universal health coverage. It's a challenge many still face.
It really makes you appreciate the thought, the ingenuity, and just the sheer human dedication behind something so ambitious. It feels like a living, breathing thing built on collective effort.
It does. And it sort of begs a fascinating question, doesn't it? As global health challenges keep changing, think climate change impacts, new pandemics, and given the scale here, the principles of equity and community participation, what new innovations might empower local communities even further to take even greater ownership of their health outcomes, pushing beyond the frontiers of this already remarkable system?
What's next? How do you empower even more? Something to ponder, definitely, as the world keeps adapting. Thank you for joining us on this deep dive today.